What is gastrointestinal motility? It deals with a lot of things that people experience, but few understand. You'll understand it in a couple of minutes. The Health Source podcast starts right now.
You are listening to the Health Source podcast, presented by the Marshall Health Network. Now here's your host, Rick Lord.
Welcome inside the Health Source studios on the campus of Marshall University. I am your host, Rick Lord, for another episode of the Health Source podcast brought to you by the Marshall Health Network. And today we are going to be talking about gastrointestinal motility. You might be thinking, what is that? I certainly was. I had to look it up and do some research on it, but we've got the expert in the house today. This is Dr. Sandeep Verma. Gastrointestinal motility. First of all, thank you so much for your time today. We appreciate you joining us. Talk a little bit about your background and what got you into this field, and then we'll do a deep dive into exactly what it is.
Rick, thank you for having me here. It's a pleasure. And I'm very excited to talk about GI motility. My background is I'm originally from India. I've done all of and most of my training in Baltimore. And I was really good at physics. I always wanted to connect it to medicine somehow.
Sure.
And finally, I found a field which involves both. And GI motility patients are the most complex patients in medicine.
Wow.
So that really got me fascinated, and one of the reasons I chose this field.
Well, you talk about, when you say something like that, that's a bold statement. The most fascinating, complex patients. So let's dive into exactly what it is, because it deals with a lot of gut issues, gastrointestinal issues, reflux, constipation, IBS, all of that. So what is gastrointestinal, for Cliff's Notes version, gastrointestinal motility?
So motility is basically anything to do with motion, right?
Mm-hmm.
So consider your entire GI system as a conveyor belt or a tube. And then it has nerves, it has hormones, it has a bunch of other, natural sphincters that is helping move the food along, help digest them, and a lot of bodily functions. So any disruption to any of these subfunctions will lead to motility disorders. And I think that is just the essence of what GI motility deals with. And it affects from day-to-day life and day-to-day symptoms.
And that's a great way of putting it, because it's something that people can understand. Like, okay, a conveyor belt moving food along. We've heard that phrase before, the food's passing through, moving along. So from esophagus to colon, walk us through that process. What is actually happening as the food is moving along?
So you would not believe it. Like, even before we are intaking the food, just the thought of food can start the salivary secretion. So the digestion starts right there. And as soon as somebody eats or swallows, it goes through our oral cavity. So there are multiple phases of swallowing, and there can be difficulties in swallowing, not just in the esophagus, but even the oral cavity.
Okay.
Happens a lot of times when somebody has had stroke, some oral trauma, some oral infections can also cause it. And then it comes down to the esophagus. So if there's some issue involving the nervous system, some obstruction, or just the muscles in the esophagus, that can cause a lot of swallowing difficulty. And the patients can present with, or they can be like, oh, the food gets stuck here. I get a lot of chest pain. We always try to rule out some cardiac causes of chest pain, because that is something that will kill you, right?
Sure.
So we want to rule out, and nothing is happening in the heart that is causing this chest pain. But once that's ruled out, it's still persistent, happening with all the meals, then something serious is going on in your esophagus, and that needs to be evaluated. And from your esophagus, it enters the stomach. Stomach has musculature of its own. It's not just a pouch. It's very specialized. It's unbelievable how complex the stomach is.
Oh.
It has pacemaker cells similar to the heart.
Really?
They start the rhythm, and that helps empty the stomach, move things along. And if there's any disorders or issues with these cells, or the stomach is affected, it can cause delaying in emptying, and patients can start feeling, oh, I'm bloated all the time. I feel full as soon as I eat, or as bad as I have terrible pain, or I don't even have any more appetite. So they can present with all different symptoms, and this is something called as gastroparesis. It's pretty common, can happen due to X number of reasons. and going down along, we enter small intestine, and same thing. The food transits through there. A lot of digestion is still occurring. Digestive hormones come, juices come, they digest, and there can be so many conditions even in the small intestine. The more common ones we experience and see a lot of bloating. So that can be something underlying called as SIBO. SIBO is something everyone would have heard, but not truly that they understand. It's called small intestinal bacterial overgrowth. So bacteria just overgrow in your intestine, a small intestine, and they produce a lot of gases and can cause bloating,
Inflammation.
discomfort. In more serious cases, they can even affect how you're absorbing and digesting the food, can cause a lot of malnutrition. And coming along to the colon, the large intestine, and it's a colon cancer awareness month, so I think it's even more important to talk about colon health. We are seeing more and more younger population getting colorectal cancer, which is so unfortunate.
Now, I'm going to stop you right there because that's such an important point. I think a lot of people have read that recently, that we are seeing an astronomical increase in younger people getting colon cancer. How much of that is maybe that it's actually could be a good thing that they're catching it,
Yeah.
where in past days maybe they weren't, or what are some factors that might be at play here?
So that's a very good question, Rick. The screening has helped bring down the colorectal cancer rates in more older population, like anyone above 60, 65.
Because it used to be that if you were
Right.
under 40, or
Right.
no one even thought about it. Like,
Right.
I'm not even going to
Right.
worry about it.
Now it is the top reason for cancer-related deaths in the age group of below 50 in United States. More than 150,000 people will be diagnosed with colorectal cancer just in 1 year, in 2026. So that's close to 45 patients every minute.
Is diet affecting this? What's going on?
So I believe, with my microbiome background or my understanding and the studies out there, scientific studies, I think it's all the processed food and our lifestyle changes, what we're eating is always, the older saying used to be, you are what you eat. So I think the kind of foods we are in a rush. We live in world of instant, gratification. Everything needs to be done
Microwave
that
society.
instant.
Yeah.
So I think that is what is causing a lot of these changes. And we're seeing cancer being, detected in younger patient age groups now.
Well, you were right when you said it's a complex issue because you're not even finished yet. We're already going down to the large intestine and the colon.
Right.
You mentioned gastroparesis. We'll get to that in a second
Right.
because that's a big thing that people probably don't have
Right.
a good understanding of. But we'll start in the stomach because I think a lot of what's trending right now is gut health. You hear that everywhere, right? Gut health and microbiomes. That's your background.
Right.
Talk a little bit about what exactly gut health means to you, and define it for people who might not have a specific understanding of what all goes into a healthy gut and how that affects other parts of your body.
I feel diet is so personal. What is healthy for you may not be for me, or my healthy
say
is
that all the
different
time.
for
Yeah.
a third person. I think at the end of the day, everything in moderation is the best way, or the thumb rule that we should follow. If we are overdoing something, we already know we are overdoing it. I think most of us have self-awareness, what is unhealthy, all the sodas, sugary drinks, fast foods. They're called fast food for a reason, and now they're transitioning to other things slowly because they're not the healthiest things to eat. So I think gut health overall, if you start seeing something which is not normal for you, go and speak to your primary care physician, or go and see a gastroenterologist. If it is more complex, go and see a motility doctor. But start paying closer attention to your body or your health in general, and gut health comes an integral part of it. So pay more close attention to what you're eating and how it is going to affect your body.
And we've seen a lot of advertisements for foods that have prebiotics, probiotics.
Right.
Can those help? And furthermore, when we're talking about microbiomes and gut bacteria, there are a lot of healthy bacteria in your gut. How do you feed that bacteria to help you become better?
So each of us have very different microbiome composition, and part of it is defined by what we eat, what our internal immune system is, and then where we live. We even share microbiome with people we live with.
Yeah.
So probiotics, prebiotics, I'm a little biased. I don't think the current generation are effective enough or efficient enough because they don't really engraft or stick. So it's still work in progress. All of us in the microbiome world, they're working relentlessly because the healthier bacteria are anaerobes. They die as soon as they're exposed to oxygen.
Okay.
So they're very difficult to manufacture or make commercialization out of it. So the current generation of probiotics, they're just translational.
So a simple way to say that, you can't buy it in a bottle.
Yeah.
It's all part of right? Your infrastructure of your own body. and
Exactly,
health, right?
exactly. So I won't discourage people from not going with probiotics, but I think it's going to be dependent on their overall health. And if it's benefiting, continue taking it. But if it's not benefiting, don't waste your dollars and money because those bacteria will stop appearing in your poop within 4 days. It's
Okay.
just translational.
We'll get to the poop in a minute. Let's talk about, there's a difference between, okay, I feel a little bit bloated or having an actual motility issue.
Right.
So walk us through the process of diagnosing someone with motility rather than just having a normal digestive issue.
Right. So that's again a really good question because everyone will start thinking, oh, what is normal? What is not normal? So I think all of us feel bloated at some point. There are some specific foods which can trigger more gas production. The bacteria just feed on them. But then if it is not just one-off phenomena, it is, more recurrent and happening over weeks and months, then we need to start paying more closer attention that something underlying is going on. This is not normal. So that's why just being aware of your body and your gut, it's important.
So obviously time is a big factor
Right,
in this, right?
right,
If something's going on for weeks, months, then
Right.
it's probably something more than just
Normal.
a passing fad.
Right.
Are there any other factors that, like a severity of symptoms? Is there anything that you need to look out for to be like, okay, I need to go see someone about this?
So any weight loss, any changes in appetite, any out of normal pain, or bloating out of proportion, or let's say this change in bowel habit. Somebody is going very regularly, suddenly they stop going, and they have blood in the stool, or they can't swallow something, the food is just getting stuck, the liquid is starting to get stuck. All these should be alarm bells, or they have terrible acid reflux all of a sudden. They're on acid reflux medication, but now they're having some breakthrough symptoms. So anything out of the ordinary should be something alarming to them, and they should definitely go and seek some help.
All right. I guess we can talk about poop now.
Okay.
A little bit about the cause of constipation. It's something that we've all dealt with. It's just a medical term. But what are some of the things that actually lead to constipation and cause? Because there's a lot of misconceptions about what happens there.
So constipation is a really big topic in itself. It is so complex. There's so many factors associated with it. Some are behavioral, some are actually muscular. So there could be something slow transit. Your intestine is slowed down. So for that, we have studies to evaluate that. And then we have something very new and novel. It's called anorectal manometry. We can do that study and actually even look at different types of defecation that is happening, or there's a defect between the rectal muscles and anal sphincter. And based on that, there's different treatment. A lot of patients, they just unfortunately keep taking pills to help with constipation. Either they have diarrhea or the constipation just continues. But unless we target and diagnose them and make them understand what is leading to constipation, we are not truly treating the underlying cause.
Now, when you say behavioral, obviously muscular, people understand that. Okay, a function of the system working or not working. Behavioral, do you mean like behaviors that you're presenting, or behavioral as in it's in your mind, or you're psyching yourself out? I mean, or both?
I think both. So this is such a complex field, motility, and can be from so sensitive of topics. Let's say somebody had a sexual assault or a trauma as a kid, or in their teenage years.
Wow.
That's going to change everything for them going forward, or maybe not. But that's one of the common things we see as a motility specialist. And then behavioral. I've seen patients who are kids as a kid. They would basically hesitate to go poop out in the open or in a public restroom.
Like anxiety.
So they just start retaining that. and I think it just kind of becomes part of your subconscious habit. So I think that's where the behavioral component comes into picture, and it just requires a lot of retraining. And first, we need to diagnose what is going on. History taking is very important, and then comes examination, and then comes testing.
Okay.
So science and art of medicine go hand in hand. One cannot just be practiced alone. This is my belief.
And how does IBS work itself all into this? Is it a motility issue? And if so, what role is it?
Yeah, it's irritable bowel syndrome. So basically, if you just look at it from a bigger perspective, your bowels are irritated, and constipation can cause it, diarrheas can cause it. And there's very rare. We label them as mixed constipation or diarrhea, but that's more difficult to actually see because a lot of times these patients are just so constipated. There's overflow incontinence. Liquid diarrhea is just flowing around it, and if they're wrongly diagnosed, they can just be pushed into more diarrhea meds, to stop that, and that will worsen the constipation part of it. So it's a vicious cycle. So it's a complicated diagnosis. It's part of the motility, and a lot of time we see association with SIBO, small intestinal bacterial overgrowth. That's why some medications work. We even use antibiotics in these IBS patients to treat them. So there are a whole lot of, and I use neuromodulators to actually modulate the gut because there's so many receptors on the GI system to calm down that irritable bowel.
We're getting high tech now. You also mentioned manometry. Are there any specialized tests that are evolving that you're excited about?
Yeah, so I'll go from the esophagus down. So from esophagus, we have something called as high resolution esophageal manometry. It's a tiny catheter they introduce through the nair or the nostril, and this can actually look at your entire esophagus down to stomach and look at the sphincters. And by look, I mean actually pick up the motor function and how your muscles are working, how you're swallowing food, how your esophagus is actually behaving. This is not picture. This is, like I said, I love physics. So this actually picks up all those in a graphical form, and a motility specialist interprets those studies. And there are a whole lot of different dysphagias. Dysphagia is a broad term, swallowing difficulty, but there are underlying so many disorders that is leading to swallowing difficulty. And this manometry study is a gold standard to diagnose that.
Okay.
And we do it here at Marshall Health, and I'm really happy that we are offering that service. So next test which is very unique, it's called Bravo and pH impedance study. Anyone who has very severe acid reflux, they've been on a proton pump inhibitor or a medication to help with the acid reflux. They're still persistent. I think it warrants a little closer look. And if something more serious is going on, we always do a upper endoscopy to rule out anything structural.
Yeah.
That there are no ulcers or anything pathological. And then comes the motility testing. And what I'm seeing here in the patient population and across the board, a lot of patients have cholecystectomy. The gallbladder has been removed. So in those subset of patients, the regular acid medication won't even work because this is not an acid issue anymore. The bile is coming back up. So it's a non-acid reflux. The only objective way to test it is do a pH impedance study and objectively look if the acid is coming back up or this is bile. Otherwise, they can go undiagnosed and be on a wrong medication for rest of their life and be untreated.
Amazing. And, the digestive system is so complex and so intertwined. We hear stories of if someone hurts their knee or something, maybe they overcompensate when they're getting better and then they end up hurting something else because something else is trying to do too much. Yeah. Do you see the same thing in the digestive system? Like maybe if you have a swallowing problem, your body overcompensates, and to make up for that, then you start seeing issues elsewhere.
Absolutely. I think just with swallowing issues, patients start developing some hiccups. Belching is fairly common, burping, regurgitation, they bring the food back up. And I think more severe spectrum, they would stop eating or drinking because they develop this fear they're going to choke on it.
Right.
And they start to lose weight or lose on their nutrition. That's a very severe or serious concern or a topic. And then again, the other extreme condition can be basically if they stop consuming food, or they start losing weight, there can be even something more serious going on underlying. And I think that's why these testing are really important. And same thing is for colon. We do a specialized test. It's called anorectal manometry. This is to literally delineate what kind of constipation a patient has. And based on that, they can be sent to a specialist, not a regular pelvic floor therapist. These are specific pelvic floor who teach them with biofeedback.
It's amazing how specialized this has all become.
Right.
We were talking
Right.
before the podcast, before the cameras were rolling, about how this kind of just branched off from gastroenterology into its own kind of field, right?
Right.
And it's fascinating to me. And the brain can play a role in all of this too, as well. I mean, my 11-year-old, he's an anxious kid, and a lot of times he'll psych himself out and start getting stomach issues because he's so worried about other things. I mean, that plays a role, right? Stress can actually physically lead to stomach issues.
Absolutely. So gut-brain health is very real, and gut-brain microbiota even more real. So anyone who has more anxiety or depression, that's going to affect the gut, because we have more serotonin receptors on our entire GI tract than what we even have in our brain. So the effect is going to be there. That doesn't mean anyone who has, any underlying mood disorders are going to have GI disorders, but there's a pretty high causality or association.
Amazing. That's why they say that the gut is almost like your second brain.
It is. It is.
It's amazing.
And my heart lies in my gut.
There you go. And a way to a man's heart is through his stomach. We can go through all the sayings. You talked a little bit about gastroparesis, which is basically, in layman's terms, the stomach doesn't empty properly.
Right.
What leads to it? What are some of the causes, and what are some of the symptoms?
So this is a topic, such incredible topic, close to my heart. Again, it's a very complex field. I can talk for hours.
Yeah. Well, let's maybe not go hours, but long enough so that people can understand.
So with gastroparesis, you very rightly said, like, stomach is not emptying well. So there are multiple reasons for it. More or less 30% of patients with gastroparesis would have underlying diabetes, which has been uncontrolled for years and years and decades, or they were not diagnosed.
So that's a strong correlation.
That's a very strong correlation. But 50% of the patients are idiopathic or something autoimmune. They had a viral illness come and go one weekend, or a bacterial infection come and go one weekend, and they're left with gastroparesis for the rest of their life.
Wow.
Their nervous system is complete into haywire for the rest of their life. And then there's a very tiny handful. They had a surgical procedure, a nerve got damaged, or something happened, and those are more, rare kind of patients. But generally, it's idiopathic, no underlying reason, cannot be explained.
So how do you diagnose this? How do you diagnose it? Sorry.
So the diagnosis is actually pretty simple. It's gastric emptying study. It's a nuclear medicine study. The patient is asked to drink radio-labeled liquid eggs or beaten eggs, and then they take pictures of how that is emptying from the stomach. So based on that, the gastroparesis can be diagnosed. If the emptying is not well, they are called delayed gastric emptying. So this is where things get very fascinating. People know about gastroparesis, but anyone who's symptomatic enough, and let's say the study is normal, they could have something called as gastroparesis-like syndrome with the normal study.
Mimics it.
Right, exactly. So the study is normal, but they have same symptoms. So it's treated very similarly. That's why it is very important to diagnose. The average length of undiagnosis period of length for a gastroparetic patient is 5 years. So it takes on an average 5 years to even diagnose a patient who has gastroparesis. Yeah, it's a very complicated or...
That's got to be challenging, to say the least.
Right.
So, obviously diet plays a huge role in this. What are some foods on both the good and bad side that can really affect motility?
I think, again, it's kind of...
Stay away from the processed.
Yeah, stay away from processed for sure. And then it's all about balance. Everything in moderation. Avoid like more sugary foods, or I don't even have sugar at my home. I'm not saying you should all stop, but that's just the lifestyle I've kind of built up. I don't add sugar to any of my food. I stay away from it. It just helps with added sugar in my diet. And then again, whenever you're buying any food, look at the labels, read what the nutritional composition is. You'll be amazed, Rick. I was at the grocery store at Costco over the weekend, and I love Costco. So
I didn't know there was a Costco around here.
in Columbus.
Okay. I was going to say, you must really love Costco. You're driving up to Columbus.
I really do. And they're even making water with protein content in it. They're making pita chips. They're making potato chips, sweet potato chips. Everything has protein in it nowadays. I think they're just supplementing. Having said that, I think those are just food fashions which come and go. At the end of the day, just try to eat fresh, healthy.
Does fiber play a role? We've heard a lot about fiber.
Absolutely. Fiber is so important for your diet, and not so much for gastroparesis, but any other condition, especially for colon health and colorectal cancer, diverticulosis. Fiber, roughage is so important for your diet and your gut health and overall.
So what is an easy habit that someone can adopt right now? And we'll get you out of here on this, but thank you so much for coming, by the way. I've learned a lot. What's an easy habit that someone can adopt right now to support healthy digestion for life?
I think at the end of the day, start watching what you eat and how was that food made, where did that food come from, and what role it's going to play on your gut health or overall health. It's going to be a little strong statement, but it is known very well in the medical field. Anyone over the age of 45 or 50 should start cutting back on the red meat. There's a very high causation with the colorectal cancer. So I think just eating very fresh. There's so many chemicals, pesticides in our food chain now, unfortunately. I even had to install a water filtration system which removes forever chemicals. So be mindful. I'm not saying go and buy only organic food. I wish it was more affordable and, we only had organic food. That's the best food to consume. But at least eat fresh, healthy, cook, watch what you're making. And there are a lot of other recipes and ways out there to make food more affordable way. The healthy diet doesn't have to be expensive. It just needs to be more mindful.
So someone that might think that they have, and I lied to you, I'll get you out on this one, that might have some issues. I would assume that since you're a specialist, it's, a specific specialist, that you should maybe go to your primary doctor first and say that these are my symptoms, and then they would refer the patient to you. Is that accurate?
That's accurate to an extent, but let's say if the symptoms are out of proportion, and this all plays into health insurances and how that works.
In-network, out-of-network.
Right. So based on that, they can reach out directly as well. But typically, my referrals come through the primary care, the GI doctors, other specialities. I'm even trained to treat like autoimmune conditions like scleroderma. So they have scleroderma esophagus. Their esophagus doesn't work. I'm trained to even manage pre and post lung transplant patients. So they have a lot of motility disorders, and you don't want new lungs which have been transplanted, to have acid in them. Yeah. So you need a lot of optimization. So I think at the end of the day, anyone who starts suspecting they have something underlying motility related, be it any speciality, they're more than happy to refer to me.
Wonderful stuff. Thank you so much for your time. So you are what you eat. So make sure it's good going in, and it'll be good coming out, and everywhere in between.
Coming out.
Dr. Sandeep Verma, thank you so much for your time today. We appreciate everything that you said.
Thank you,
and hopefully that helped you. And remember to like and subscribe so you can help support us. That's the only way we can continue to bring you podcasts like this. For Dr. Sandeep Verma, I'm Rick Lord. Until next time on the Marshall Health Network's Health Source Podcast, take care.
That was the Health Source Podcast, presented by the Marshall Health Network.